Dr. Melody Ennis. We'll begin the conversation with the update from the Minister.
Thank you very much, Stephen. Good evening, ladies and gentlemen. Thank you once again for joining us on our regular weekly COVID conversations. Lots to explore, to discuss, to explain. This evening we have the Vaccine Implementation Plan. We will provide a review of day one of the implementation of the vaccines in the respective parishes. We don't have the final numbers as it relates to day two, just some, parts of the information. I was in St. Catherine, Spanish Town Hospital, St. Diego Health Center, and then Maypen, and can speak a little about those areas. And I know some of the information is coming in, but we certainly can give you a summary of yesterday. And we're going to be speaking to two persons who received their vaccines or jabs yesterday. Our very first Mrs. Marcia Thomas Yetman, public health nurse, and Professor Eldemaya Shearer, who received the second jab at the Good Samaritan facility here in Kingston. But before we get into those reports, I'm going to ask Dr. Webster Carr, our national epidemiologist, to go right into the latest surveillance report. Dr. Webster Carr.
Minister, good evening, everyone. We're going to start with, that's the last slide, yes, the update using data from yesterday, the 10th of March. When we had a total of 695 additional cases yesterday, bringing the total to 28,968, of which 717 were imported. And there were unfortunately 475 deaths, with a case fatality rate of 1.7%. When we look on the next slide, with respect to the age distribution, if you note, starting from the later teens to the 30s, has the highest burden of cases. Next slide. However, when we look at the deaths, the greater amount of deaths are in the older person, with a case fatality rate highest among the older persons. When we look at sex distribution, more females have been identified than males, but when we look at the deaths, more males, next slide, have been identified. And so males have a higher case fatality rate than females, significantly so. So when we look at the comorbidities and risk factors for death, 99% of the COVID-related deaths have one or more of the comorbidities or risk factors. We don't often speak about those who don't have. We have had 5 persons who had none of these risk factors for death, and 3 males, 2 females, as young as 36 and up to 54 years. So it may not be common, but the risk is still there. It might be small, but the risk is still there. So we all have to be careful. With respect to other comorbidities, persons with cardiovascular disease, particularly hypertension, 55%, 41% with diabetes mellitus, and 12% had chronic renal disease. When we look at the cases over time, starting in March last year, and in April, a lot of that in April had to do with the workplace cluster, then the decrease, and then in August, then we started to see a general increase in cases. However, we never ever came back down to what we were pre-August, and that we need to remember. And then we slowly increase over time to where we are now in March, with March 2nd having the highest number of cases of onset of 617. So this is a busy slide, but it's just to give you an idea of when what is called the reproductive rate. So each person, on average, how many persons they transmit to. So if you transmit to one person, then the reproductive rate is 1. And if you transmit to 2, then the reproductive rate on average is 2. So we see the peaks and valleys, and we see the intervention. For instance, when we had put in restriction with public gathering and bars and so on, we see a decrease in cases. Introduction of masks, another decrease in case. Opening of schools, on some instances, saw increase in cases. Closure of border, decrease in cases. So we've seen where the restrictions did indeed work, but for how long? When we look at the reproductive rate currently, it's about 1.2 thereabouts. It seems small, but what happens when we're at 1.2? If we look at the next slide, we were at about 1.3 in January, and over time, we went up from 118 cases in January to where we are now. So if we continue at the 1.2 reproductive rate, in 30 days, we could be at 1,500 cases. But if we go to 1, then we remain at about 600. If we go to 8.8, then we could be going down to as about 200 cases per day. So the lower we are, the better. And we have to maintain the reproductive rate below 1 to ensure that we continue to decrease in cases. So we need to follow the protocols for this to happen and maintain it. When we look at the positivity rate over time weekly, we this week have similar positivity of around 32% for the weeks. I must say we did identify the UK variant in persons, local cases with date of onset in the week 3 and week 4 of 2021. Next slide. So this slide is a combination slide looking at burden of COVID-19 in Jamaica by week. So the bars shows the cases given their week of onset. The red line gives the deaths by week of occurrence. The yellow line gives you the positivity, and the blue line gives you the bed occupancy. So as cases increases, the bed occupancy increases, the deaths increases, and for the deaths and the bed occupancy, there is about a week lag in time between these indicators. So what is fueling the increase? The non-adherence to protocol in all settings. Why do I say that? For example, the increase in workplace clusters. We see that restriction work in decreasing the infection rates. Other factor, interaction among teens and young adults. The highest burden of the disease is among the young adults. And we note that increase and decrease in schools opening and closing is shown. The UK variant would increase the risk of transmission based on what the literature is saying, and there is an increased risk of reinfection. I didn't put this one first because if we note the reproductive rate after we assume has been the reintroduction of the UK variant is not increasing dramatically. So it plays a role, but I don't believe it is the major factor. The major factor, I believe, is the non-adherence to the protocols. This is the parish distribution, and all parishes in general have higher number of cases. When we look at the next slide with the reproductive rates for each parish, we can look at the last line. So Jamaica is about 1.2, and Manchester is showing the best reproductive rate, probably coming out of the special restrictions that were there in Manchester and maintaining that below 1. And Portland have the highest. So when we look at the distribution by parish, over the last 2 weeks, KSA St. Catherine has had the highest burden of disease. But when we look at the rates, on the next slide, okay, this is the same slide. We can move to the next one. Okay, when we look at the parish distribution for the deaths, St. Elizabeth, Westmoreland, and St. Mary has the highest case fatality rate. When we look at the deaths per population, next slide, Trelawney, St. James, then Westmoreland has the highest deaths per population. Next slide. And this is the final slide. Over the last 2 weeks, most communities in Jamaica have had confirmed cases, and you know there are more cases that have not been confirmed. So this looking very pink, so everybody is at risk. Thank you very much, Minister.
Thank you very much, Dr. Webster-Carr, and let me just thank you and your team, Epidemiology Unit, for all the work that you have done. You know, many persons may not know, but just to say that Dr. Webster-Carr is not only a clinician, she's a statistician, and the discipline of epidemiology is about forecasting, it's about statistics, it's about projections. And sometimes, and I raise it because sometimes we ask the question, why is it, how do we know that border restrictions work or restrictions work, whether it's curfews or, and I know that there is a tendency, and with some understanding and sympathy and justification for some persons who it affects most, primarily business, individuals who, you know, survive beyond the regular day working hours, to be critical of some of the measures that we have taken. But the truth is that there is a lot of thought and a lot of modeling, or one would say, well, give me another term for it. Modeling, calculation, analysis. I want to be as simple as possible. In other words, Dr. Webster-Carr could easily be a math teacher or a statistics teacher at the University of the West Indies. Courses that I didn't particularly enjoy, but absolutely critical to looking at scenarios and projecting and predicting the future. And all the models that we have run, and she put that slide on the screen, if you could put it back up, that one on, is it easy to go up? The one with the interventions, the crowded slide. And I want to do this because I think it's important. That slide gives an indication with some simple explanation of how the cases in the country varied, moving up and down, and what decisions were taken that influence the spread of the virus at any particular point in time. And what it clearly shows is that when restrictions were removed or eased, you had more, and people moved around more, the virus tended to spread more. And that's because many persons who were moving around did not observe the protocols. They didn't wear the mask, they didn't physical distance, they didn't sanitize. And we know that it happens. I mean, I've been out there, I know, I've seen the pop-up sessions at the bars, the funerals or the grave diggings or and I could go on and on. We know that. We have documented many of those cases that have led to those outbreaks. We have seen where when the borders were open, persons started coming in. At that time in the US, the virus was raging. A number of diaspora persons came in. They didn't observe the 14 days. It spread the virus. And every time you went in and restricted movement, whether through tighter curfew hours, number of persons who could gather, lowering that number, and I could go on, then you saw after a while the R0 or the reproductive rate coming down, and overall the numbers came down. Now, many persons have been very critical of this strategy. It's universal. It's done in a very deliberate way, and there's a lot of calculation that goes into it. And what we have done is ask for a team of experts, including someone who is at the Centers for Disease Control, someone at Howard University, and and Purdue University, very acclaimed universities, and in the case of the CDC, important agencies in the US, and our very competent team here, led by Dr. Webster Carr, who could be at any of these places if she wanted to, but she has chosen to be here, to do a study, an assessment of the numbers, and to present it in a very scientific, structured way. And I intend to make those conclusions of that study and the study in as simple a way as possible available to the public, because I do believe we need to learn from this pandemic for future reference, and we need to recognize that many of the decisions that the government has taken has been informed by data, by modeling, by significant effort of statistical application, and hence where we are today. Now, in saying that, based on the most recent restrictions that we have had, there are signs, and I put it no stronger than that, right, that we are seeing a sort of plateauing of the increases in terms of the reproductive rate, looking as if it may want to adjust. And that's a good thing. That's a positive sign. But it's very early, and we don't want to say it in a very conclusive way. But I think it's very important just to say that we do not take these decisions in a vacuum, nor do we take them without significant consideration and efforts that have been put out. And I really want to commend Dr. Webster Carr for her efforts. Beyond that, her presentation indicated very clearly another pandemic that we have never really recognized as such, and that is the incidences of lifestyle diseases on our population. 99% of our deaths in this COVID-related deaths, are persons who have had at least two comorbidities, two or more comorbidities: hypertension, renal failure or diabetes, cardiovascular disease, all of these have contributed to weakening your immune system and your ability to resist or to fight back the COVID-19 virus. And most of these persons are over 60, but there are a number of them that are below 60. And what it says to us as a country, with 70% of our deaths linked to lifestyle diseases, is that we have to get back to not just clinical science, but behavioral science to drive behavior more towards healthy living and healthy lifestyle. A narrative that's often ignored, but so absolutely critical in moving forward, and is reflected again in the COVID numbers. And the final point I want to make is the fact that our hospitalization and deaths, and today is a sad milestone in that we have had to report the largest number of COVID-related deaths in one day, 12. It's a sad milestone because every death is regrettable, but having the highest over the last 12 months related to COVID is regrettable. It's sad. It's unfortunate. But the relationship between number of cases number of hospitalizations and number of deaths cannot and should not be ignored. And what we therefore need to do is to observe the protocols, take special care to bring those numbers down. And that's what the government policy is all about. Now, in terms of the day one vaccination review, in keeping with the plan that we unveiled some time ago, we started exactly 1 year after the first COVID case was discovered, March 10th, 2020. We started a vaccination program on March 10th, 2021, a real significant occurrence, and coincidentally so, but nevertheless tells a story. 1 year we have been at it, and we are now embracing vaccines as an important part of the response to COVID. We had 39 vaccination sites across the island. Our original target, and I know we have said a few different numbers over the last day or half a day, because the numbers took a little while to come in, and we crave your indulgence and your understanding if you heard 29 6 hours ago and you're now hearing 39. So we had 39 sites. 33 were originally planned, but for whatever reason, the regions adjusted. So we actually exceeded the number of sites that we had originally planned. The goal was to inoculate approximately 3,280 members of the priority group, which were, of course, healthcare workers primarily. We started at 8 a.m., ended in some instances at 10 p.m., and at the close of the day's operations, we were 2,718, or 83% of the target population for day one. I think that's a good achievement. It's a commendable achievement, even that this is the start of a national process, and in a sense, it was a trial run, if you will, or a real run, and we really started in a manageable way to pick up any learning experiences. But 83%. We thought was good. Now, the numbers will go up when we get the numbers for the JDF. My understanding is that it will go up to about 89% or close to that. We don't have the final numbers as yet, but the JDF was in fact administering their own vaccines. They have a medical unit there. Notably, the Western region exceeded its target of 530, inoculating some 804 persons. So significant achievement. 152% of target. Northeast region hit 99% of its target, 514 persons vaccinated. That's 6 persons short of the target for the day. The Southeast and Southern regions were short of target, 63%, or 1,208, and 64%, or 192 of those targets, respectively. We will adjust as we go. We will investigate to find out why those targets were not met, make necessary adjustments where necessary, but it's an ongoing process. So, and of course, set more ambitious targets in the cases where the targets were far superseded. The majority of the sites were hospitals and health centers, and 3 of the 4 regional health authorities exceeded their targets for the number of vaccine sites that were to be open on day one. And our aim in the next 7 days is to inoculate some 17,000 persons over the next 7 days. So we're targeting 17,000, continuing with our priority groups, healthcare workers first, and depending on how far we get in that group, then we move to the uniform officers of the constabulary and the JDF, which has already started. To give us some better particulars on the day one operation, I'm going to ask Dr. Melody Ennis, Director of Family Health and Clinical Lead for the Vaccine Implementation Program, to quickly put a few slides up and very quickly just run through. And by the way, that's the logo for the COVID-19 Vaccine Implementation Program, which speaks to human well-being, equal respect, national equity, legitimacy, and reciprocity. And those are important themes that drive the program. Dr. Ennis?
Thank you very much, Minister. Good afternoon, everyone. So the anticipation was over and the vaccines landed on the 8th, and as committed, we were able to begin our vaccination process, certainly within 48 hours of the vaccines coming into country. We had anticipated just a smaller amount of facilities being open on the first day, but as Minister indicated, we did exceed our expectations and more facilities were indeed open. The first slide really is just telling us that we are reporting on but one day of activities, and that's the day of the 10th. So we have pretty much completed about 16% of our target for the week, which is a short week, just 3 days. Next slide, please. Now, Minister really did go through this, but I want to draw your attention to the fact that of the sites that were opened, every single region was able to open what was stated or more, with the exception of the Southern Regional Health Authority. And it is important to also note that a lot of the sites in that region opened in the afternoon. They opened at 2, and our data capture ended before they could account for some of the numbers. And that explains some of the shortage that we're seeing in this slide. But it's really important to understand that 83% of our target was met, and I believe that that is indeed commendable. Next slide, please. Now, we are looking at the male-female ratio of persons receiving the vaccine. And if you recall from Dr. Webster Carr's presentation, the deaths are high among the males in our society. And therefore, we're beginning to look carefully at this gender distribution, because women are accepting the vaccine much more. We know for sure that our health sector is skewed with lots of women, but we don't really want this trend to continue as we roll out, because we recognize that men do fare just a tad bit worse than women. And my encouragement, of course, is gentlemen, please get on board and get vaccinated. Next slide, please. And this is just the age distribution. We well know that our retirement age, 60, 65, therefore not a lot of persons would be in that category. And the vast majority of persons, of course, fell between the ages of 40 and 49, followed by 50 and 59. 60 to 69, a small number. And of course, not a lot of very young persons would have been vaccinated on Wednesday. Next slide, please. And the parish distribution, the Emmy goes to the Western region that exceeded their target. St. James did quite well at 466. But of course, the Southeast region, Kingston and St. Andrew, wasn't to be outdone. So they did come in second, and the other parishes, as you can see. Next slide, please. And this is what everybody is waiting to hear about. The events that's supposedly attributed to vaccination or immunization. In short, the reactions, the adverse events, the allergic reactions that we've been hearing about. So we had a few events that were of concern to us, and it numbered 12. So of our 2,718 persons that were vaccinated, we had a concern with 12 of our patients. In Kingston and St. Andrew, it was actually 6. And what were some of the things that we noted? Dizziness. You may have heard that dizziness is really one of the side effects of receiving the vaccine. It lasts maybe for about 15 or so minutes, and then persons are well. So we have noted dizziness in 4 of the patients in Kingston and St. Andrew. You have been advised that we do observe persons who are vaccinated, and these persons were simply allowed to lie, and really in 10 minutes they were up and out and were able to drive away from our center. Dizziness and nausea, and one individual had an episode of vomiting. Now, in St. Catherine, we noted 2 of these events. Someone had some swelling, similar to if you have an allergic reaction to something you eat, you get a swelling and a rash. That was treated with just oral medication, DPH, what you could get over the counter, and it resolved. In Trelawney, we also had 2 persons who had a rash, and in Westmoreland, someone had dizziness. All of our 12 patients, their condition lasted less than 15 minutes, and they were able to leave our facility and are doing well. So, in summary, of our 2,700 plus patients, we looked carefully and observed just 12 for a little more than 15 minutes, and their outcome has certainly been good, and we are grateful for that. And therefore, we are beginning to build our own database with the evidence that this vaccine that we are administering is indeed safe, and we know it is efficacious. So we move on today and for the rest of this week to vaccinate our most vulnerable, the healthcare workers, some of our elderly population, and of course, our uniformed officers. Thank you, Minister.
Thank you very much, Dr. Ennis. The issue of events attributed to vaccine or immunization, which we call ISAVI. ISAVIS. Yes, ISAVIS, okay, I've got it now. ISAVIS for short, is a report that's generated just to be very transparent and to say other things, more importantly, that the side effects that tend to dominate the pushback or the objection to vaccines are not as, should I say, valid as some people make it out to be. They, in fact, a critical part of the process is for counseling to take place, and every location has the infrastructure. They prepare for persons who may have an episode or a mild episode. In the counseling session, you're told that these are possible side effects. And that's why we have an observation period for persons to spend 20 minutes to half an hour just to ensure that they're okay. And they get the brochure with all of that and simple application of treatment. I mean, you know, if they have a headache, they take a Panadol, that sort of thing, right? I mean, it's the long and short of it is that for that mild side effect, you have prepared yourself with the protection against COVID, which could be detrimental, particularly if you fall in that vulnerable category. So it is well worth it. And I know questions will be asked later on about the AstraZeneca vaccine and the news that has come out of 1 or 2 countries in Europe. Our position is that we remain committed to the vaccine and the efficacy of the vaccine as stated or outlined by the experts at the WHO, and even more recently this morning by Professor Peter Figueroa, who is part of that expert panel by AstraZeneca UK that has sent out communique, and the WHO's position remains. And, you know, the vaccine has been administered to millions of persons so far around the world, and we have not had incidents that could change that expert view that it is an effective and safe vaccine. And we will track the persons here in Jamaica that receive the vaccine, as we have done, to show the actual impact. And so far, so good. All right, so just to note that the country is expected, on another matter, to receive 14,400 additional doses of the vaccine through the COVAX facility. These doses will arrive on Monday, March 15th in Kingston, and this will represent the first installment of a total allocated 124,800 doses to be received through COVAX. The remaining allocations are to be delivered by May 2021. I know persons are asking why the shifting dates. We don't determine the dates. You know, we have paid into a pool. That pool is managed, and we are told when the vaccines are available. We're given numbers. We quote and make those numbers available. The truth is we have had a revision of those numbers, but it has not been up to us. It really is up to the program we have bought into, and they have given information around production issues, production scheduling, and there are other issues, as you know, in terms of some of these manufacturers having to commit to other parts of the world based on government policies that have shifted and so on. Nevertheless, we're hopeful and we remain confident that we will get vaccines. The issue is just a matter of timing. So next Monday, we will get our first shipment of COVAX and our second shipment overall, which will allow us to continue the program. Beyond that, we have 1.5 million doses to be supplied, 1.8 million, between April 2021, beginning April 2021, under the African Medical Supply Platform. And we've spoken about that. That, as I understand it, is still on track. If anything changes, we will let you know. And the mandate remains to identify and source some 4 million doses of vaccine by March 2022. And the target there is to inoculate some 65% of the Jamaican population. On vaccine supplies, I think it's important for us to be as frank and as straightforward and as upfront as possible to the population, which is, we don't manufacture vaccines in Jamaica. This is an extraordinary circumstance globally. There is a mad rush by all to source vaccines. Countries that are more powerful by resources, by their links to manufacturers, by where those manufacturers are based, have in fact exercised the advantage that they have to secure supplies, sometimes well beyond their population. And so vaccine equity has been in jeopardy in terms of access to all, despite the efforts of the WHO and facilities like COVAX. And in addition to that, I've been told up to recently that there have been some manufacturing issues in some countries in terms of raw material. When you combine all of that, it does impact our ability as a country in the region, small country, to access ideally. Having said that, we don't want 4 million doses of vaccine at the same time, because some of it will spoil. The AstraZeneca vaccine has a shelf life of what, 6 months?
6 months.
6 months. So for us to bring in 3 million doses of AstraZeneca, given the amount that we're administering over a period of time, we would waste some of it. So it has to be scheduled. And so what we have now is good for now. We hope to pick up more as we go along. That's an important thing to note. The second point is, we want vaccines that are WHO approved. That has been our tradition, that has been our culture, and that is what we have relied on to deliver safe vaccines to the population. And yes, there are offers for vaccines that are not approved yet by the WHO. Our principle is to discuss, to negotiate, to go in line, to wait, but then to access once the experts sign off that these vaccines are safe. And we're involved in several of those discussions. So we're not sitting around waiting. There are several avenues that are being explored. And my own view is that the vaccine market will become a lot more accessible, if you will. May, going into the summer months, by then production will catch up with demand. But between April and May, and April is a crucial month, the market is going to be tight. And so whatever we get, we will appreciate and we will use. But that month of April, I expect to be a very tight month because demand is far outstripping supplies, particularly for WHO-approved vaccines. In terms of the implementation plan, the rollout will continue, and there are a number of areas of the plan that we will discuss at another next week. I did say at the OPM that we would go into more details on the structure of the management arrangements of the plan, but there are two elements of it that we are going through and fine-tuning. as it relates to the phases of rollout and how it is managed and the relationship between the public and the private sector. We are going to be having a conversation at Cabinet on Monday to introduce a few other components of the plan, and we crave the public's indulgence to allow us to do that, to get Cabinet's discussion, input, and sign off, and then we present. Having said that, we are very comfortable with the plan that we have in place now and the rollout that is taking place now and the commitment of the key personnel on the ground in the regions, and we do believe we can meet the targets that we have set. So it is in no way going to affect what we're doing at this point in time. As stated, there will be a phased implementation of the plan, and one of the things that has generated a lot of questions is the issues around who is eligible. When is the healthcare workers are clear now. When are other persons outside of JDF and the police? When are government officials? When are the professional groups? The plan is there, and the plan outlines a phase. I know there have been some occurrences which has created some anxieties within the population. A website going up, for example, by one of the regions, I think it was that, and in one instance by one of the professional associations that persons have been filling out, and in anticipation that they would get appointments coming up soon. I just want to stress that right now, the management of the plan dictates that healthcare workers are the priority, frontline healthcare workers. We deviated a bit from that yesterday when we invited former prime ministers and other key influencers, many leaders in healthcare, to promote the concept of taking the vaccine, because it's an important part of the take-up, the messaging. But healthcare workers first. The JDF is doing their own, and they have the capacity so to do. And we're working with the constabulary, the JCF. They can do some on their own. We will work with them to do. Those are the priorities. And then we move into the 60-year-olds and over. I mean, there may be some overlap, right? Don't get me wrong, but that's generally where the priorities will be. Now, as it relates to the 60s and over, in very short order, but not yet, we will provide public information on the specific details of registration to secure an appointment. The plan speaks to a toll-free number that is going to be manned by a BPO firm. The plan speaks to a website that you can upload information, your doctor that will capture information around the 60-year-olds and over and provide that information, which will generate an appointment. The health centers and the clinics that will have that kind of database. And even for walk-ins, visiting your nearest health center will provide that information. The plan does cater to persons who are at home and not mobile because of age or restriction. And where we have to go to persons who need a vaccine, we will do that, because the plan does have a mobile component to it. Our public health nurses are out in the field. They know a lot of the people. And we're working through the regions, tapping into the political infrastructure of councillors and MPs and so on, for them to contribute or participate. So I say to the public, give us another week or so, because the plan really was, or had anticipated, that the 60-year-olds and over would begin April, early April. And so for the next few weeks, it really would be healthcare workers and the constabulary and the JDF. As I said, there could be some overlap, but we will give you sufficient notice in short order. Just to close on this, I would like to announce too that Cabinet has approved the government's partnership with UNICEF for the deployment of a vaccination management system with a registration and scheduling module that will make the process of registration seamless. So there is a software platform that is going to be utilized. The system will be accessed through the websites of the ministry, the regional health authorities or through a call center that will manage the process of setting up appointments. And the system will be launched closer to the period of full rollout, as I said, late March, at the latest early April. So we do have and are putting the infrastructure in place to ensure that your appointment is secure. So no need to be anxious. In the meantime, just follow the protocols and protect yourself. All right, I think I've spoken very long, maybe boring too. So Stephen, let us go right into celebrating the first 2 persons who received the AstraZeneca Serum Institute of India vaccine yesterday, starting with our public health nurse, Mrs. Marcia Thomas Yetman from the Southeast Regional Health Authority. And I understand that she's on the phone. Is she on? Okay, on Zoom. Oh, on Zoom. Hello, Nurse Yetman, how are you?
I'm fine, thank you. Good evening, everyone. Good evening, Mr. Minister.
All right, so first things first, you're alive.
Alive and kicking.
All right, after that job, right? So tell me how you
Yeah.
how you feel exactly. It's more than 24 hours because you did it in the morning at 8 or a little after 8. So it's almost 37 hours. How you feel 37 hours after getting the vaccine?
I'm feeling fine. I'm not having any experience out of the ordinary. As would be expected, there's a little tenderness at the site and a little tenderness in the axilla on where the arm was vaccinated. And that basically is it. A little tired now and again, I'm not sure. Those are expected experiences persons would have, and we were told that we would have had those.
So you went to work. You went to work today.
Yes, Mr. Minister, I went back to work after I got the vaccine yesterday.
What?
And I went to work today.
I don't want you to give. Go ahead. Sorry.
I was just saying to someone that the rain wet me yesterday. People always say when you get wet by the rain, when you have injection, all sorts of things would happen to you. And I got wet by the rain and I'm fine, no fever. I'm doing well.
Well, first of all, I don't want you to give the impression that we're a wicked set of people at the Ministry of Health and send you to work after you get your vaccine, right? So I'm just interpreting that you are a committed hard worker who saw the need and took it on your own self to go to work after you got your job. Is that so? Say yes, please.
That is so, but then there is no reason to stay home. I am not sick.
Right.
I'm not sick. And so I'm able to work and do my normal functions and go up and down as normal.
All right, so tell us about the process. First of all, you're a nurse, so you know these things, and you have been out there. I don't know if you administer vaccines yourself, do you?
I do. I didn't do any today or yesterday, but I do vaccines from time to time.
So
I'm an immunization officer.
Oh, excellent. So can you tell the public in your own words why vaccines are safe? And because I'm sure you do counseling too, right?
We do. Vaccines are safe. We have been giving vaccines to our children for decades. As a matter of fact, the same manufacturers of the COVID that we are administering to persons now for protection against COVID-19, they are the persons that supply us with several of the vaccines that we're administering to our children. And so I have full confidence in the vaccine. We have established over the years that vaccine is one of the most reliable ways of preventing disease condition, and it is cheaper than having to treat conditions when persons are infected with diseases that are transmitted from person to person. And this vaccine, in addition to other vaccines, are safe and has been established to be safe for persons to get. And so I'm quite confident and happy about it.
Excellent. And tell us a little about the process yesterday, because you know, some people are afraid of needles and they're afraid of doctor-type environment. And this was you're administering vaccines. How did the process go in your estimation?
The process it's very simple, and I've been to many of the sites and observed what is happening to persons who are vaccinated. When you go to the site, you're first counseled before you get the vaccine. So you're told what to expect, what is going to happen as you move through the different stages at the site. So the counseling, you have registration and you have counseling. Then you move on to the section where you do your vaccination. You are given the vaccination by the nurse, and I can tell you that it is painless. As I told persons yesterday, I am one of the healthcare workers who is afraid of injections. And so when I got mine, I was really very surprised. I was mustering up myself, expecting it. You didn't see it because I had to be very careful what I showed. But I was really inside saying, yes, Lord, injection needle. But I was pleasantly surprised that it was painless. And it went, and for quite a number of hours, I had to be feeling the spot to make sure that, did I really get an injection? Well, and it was really very pleasant.
Well, I tell you my little secret, and maybe the viewers can adopt it. When I go to do my annual physical, and they have to take a lot of blood to check off everything, the first thing I tell the lady collecting the sample is, listen, don't show me the needle. And I look away. It's not until she finished that I realized that she actually was putting a needle in my arm. So that works for me. Maybe it will work for others than you. But I saw you. You were very brave, very bold. And of course, you did it under extraordinary circumstances in that there was no privacy. You consented to an entourage of cameras and in effect became a history maker in Jamaica, certainly in the context of COVID-19. Very proud of it, very proud of what you have done and the work that you're doing and your team. What would you say finally to those out there who are contemplating, because we still have a lot of doubt out there around COVID, around the vaccine. What is your advice and encouragement?
I would encourage everyone, please go and take your COVID-19 vaccine when you can get it. It is much cheaper, much less painful than going and being exposed to the COVID-19 infection that can result in very terrible complications, hospitalization, and even death. So I would recommend, highly recommend, and having received it myself, I am happy and I'm looking forward to my second dose of the vaccine. So we are doing the tiered approach. Persons are being asked to come at different stages. And so when it is your turn, please turn up to the facility, get your vaccine, and protect the rest of us. We really want to go back to life as normal as possible. People have to be staying on lockdown, curfews, and all of those things. So we want to get back to our normal lives. And this is one of the ways that we can protect ourselves, get herd immunity, and go back to life as we knew it before March 2020.
Nurse Yetman, you are a superhero, a super healthcare hero, and deserve all the accolades and the praise. And I had no doubt that you were alive and well, because I believe in the efficacy, the safety of vaccines, and in this instance, WHO approved vaccines. In fact, I have a big mark on my arm right here from the chicken pox, measles, and mumps jab that we all got in our early years in primary school. And I'm still here, right? And I think I'm doing all right. So thank you very much. I really appreciate it. And thanks for the work that you do. Really appreciate it. Thank you. Have a good evening.
Thank you, sir. Good evening.
So there you have it. Nurse Yetman, having had her job, the first person, public health nurse. She's alive and kicking, went to work the very same day, back at work today, and she really preached the virtues of vaccines to the population. And she should know, because she's a vaccine administrator, if you will, and she's out in the field. I'm sure she would have seen many persons grow and mature, having given them their job throughout her career. We have another very celebrated Jamaican, a healthcare hero herself, but a hero in many other respects, a professor at the university system, Professor Denise Eldemire Shearer. And she was the first person over 60 years old to receive the vaccine. And I think she's smiling. Right, Prof?
Very much so, Minister. Very much so.
Tell me about it. Well, I was there and I saw you. It's almost as if the thing just never really mattered. You just go in and do your thing and you were good.
And that about represents it, yes. Like Nurse Yetman, I also went back to work, so patients in the afternoon was at work today as well. And very similar experience to her, a little bit of stiffness in the arm, but only in the afternoon. It had gone by night. Nothing today. You have to touch the arm. And I've had flu shots every year since the 90s, and you usually have a little bit of redness, certainly a little bit of soreness. Tox, you usually get a swelling. None of those things, Minister. And I feel fine.
So, Prof, you actually provide clinical management to the older population, and you
Yes.
would have been quite sad about the mortality rate of COVID on your segment of that population that you treat, you give advice to each day. Tell us, help us to understand what vaccines represent in the context of this period that we have gone through for that population, and why it's important to take it.
The mortality, yes. There's also, we are seeing tremendous depression and anxiety. This is a group of people that have been on the stay-at-home order for now 12 months. So the social isolation, and Minister, we had given you some statistics on that, the loneliness. When it started, families, pitched in and everything, but then we had stay at home for schools and families have been stressed. So there is the mortality. And remember, not just the mortality. What we are seeing in some of these older people with long hospital stays, and you had one of those ladies on your program, they continue to have respiratory type symptoms, the coughing, the shortness of breath. And so for both the clinical reasons and the emotional reasons, only this week, a lady was convinced something was wrong with her. And when I did her blood and everything, nothing was wrong with her physically. And she admitted, I just can't take this locked up in the house anymore. She volunteers with a church. So this vaccine is the start of giving our older people back their everyday life. That's basically what it is.
What is your indication of the level of take-up for the vaccine in that population, based on your experience with that group?
Well, Minister, I already have 500 names, if that gives you any indication, and people are calling. We're doing the front sheets. We're just waiting to be told what to do. I believe the take-up is going to be high in this age group. I think, as Nurse said, this age group, they've been very good with the stay-at-home, Minister. If you notice when you're driving around, even at the funerals, you're not seeing old people out on the street. Think about it. They have paid attention to the stay-at-home. They are petrified of COVID. They don't want to die. And they equate COVID with death. Right. And therefore, for them, this is going to be about going to their regular appointments, whether it's their follow-up appointments. It's about going back to church. It's about going to the neighborhood community gatherings. So it's about getting back their life. So you are going to have a high uptake among older people, and they are ready. They're honestly ready.
And for us in public health, we would like, as quickly as possible, to ring fence that over 60 population, numbering, I think, somewhere in the region of 200 plus thousand. We don't just want the 2/3. We want the entire, the 100%. But there are some
350,000.
350. There are some
350.
There are some that are doubtful. Just help us. I'd love you to give some advice to them, but also explain what is the expected side effects. Are they any different from anybody else? They're under 60s in terms of the vaccine.
Well, Minister, from what I've heard today from various programs, we're actually doing better. We're actually having less of the side effects, but then that's only a study group of 2. But I think that it's just to warn them about the soreness. If we take a step back, you said you had measles, mumps, and rubella. That means you're considerably younger than me, because I didn't get it because it wasn't around. And therefore, we need to approach this group on the basis of what they know, which is the flu vaccine and Tetox and those, because they didn't have the measles, mumps, rubella, and to explain to them what a vaccine is. It's a jab in their arm that doesn't have any laser or any of these other things that we're seeing on signs. And that's going to make their immune system able to fight COVID. They may still get it, but they will not get severe illness. And most importantly, they won't infect the loved ones around them, because for older people, the loved ones are often their mothers and their fathers. I have a number of people who are not only talking about themselves at 70, but the mother at 93, the father at 95. So it's about assuring them. Some of them take insulin. It's like an insulin. The syringe looks very similar. And tell them that this is about quality of life.
Right. So where do we go from here? Having had the vaccine now, how do you feel in terms of, because one of the things that we have been discussing is that there is a need to still be cautious in terms of exposure of the virus. I mean, how would you, what's your new modus operandi, if you will? How do you move from here, given that you've had the vaccine?
Everything stays as before. Okay. So masking, social distancing, being careful. Even after the second shot, there is a period that is 4 to 6 weeks, depending on which literature you're reading, that says you still need to be very careful. I don't think that we're ever going to go back to 2019. And I keep saying in my messages, when we get back to safe normal. And I think we have to wait to see whether booster shots are going to be needed. But I think we need, Minister, certainly the social distancing in some forms, if you don't know people. We need to hug. We need love. And we need our older people to be able to hug their grandchildren. So I think we're going to have to work out a new set of guidelines. Clearly, you keep your distance in the supermarket with strangers, in the pharmacy, etc. And that you stay within a family type of situation. But I think we're still it's going to be normal, a new normal. But I do believe it's time for older people to not have the restriction, obviously if they're safe, because we don't want them to die. So they can come out for their walks in their community. I'm seeing tremendous muscle mass loss, Minister. You exercise, so you know when you don't exercise for a couple of weeks. These people have not exercised for 1 year. These are some of the things that we're seeing, that we can say, go back to your morning walks, the hour around your neighborhood, take off the mask if nobody's around you. But we still have to stress that getting the vaccine is not licensed to go back to what it was like in 2019.
Professor Lemay, thank you very much. We really appreciate your coming on, appreciate your testimony and your endorsement of the vaccine program. It's so important, particularly for that group that you cater to, over 60s, and we want them to take it quickly because we want to keep them safe.
Minister, thank you. I as you saw my face yesterday, it must have been one of the happiest days in my life.
Okay.
No, seriously, to know that the start of the protection was the start was there.
Thank you very much. Have a good evening. Okay, so
too.
There you have it. The two first persons to receive the COVID vaccines yesterday. Both are bubbly, healthy, and speaking confidently about the process. And that's a good thing. And I really hope that the rest of the country will take note and will be willing when their time comes to take the jab, the vaccines. Before we go to the questions, or maybe I should go to the questions now, Stephen, and then close with the other comments. So we're going to go now to questions. A number of persons online. Stephen, your time.
Thank you, Minister. Just reminding our media colleagues on the Zoom to use the raised hand feature if they want to pose a question to the team. We're going to begin with Emma Lewis.
Yes, hi, good evening. I have a couple of questions. The first one is, what is the actual timeline for senior citizens? When will they be brought in for vaccination? I'm still not quite clear on that. And secondly, what is the plan in terms of ongoing public education regarding COVID protocols, mask wearing, etc. Because I believe this is still a problem. You're still putting out pleas and trying to persuade people to wear masks and not crowd up and all that kind of thing. But I wondered what kind of program might be in place, particularly for communities, on the ground public education. Like, have you thought about town criers? Are you starting to use them? Our MP was using a town crier this week, which I thought was very good. So those are my two questions. Thank you.
Thank you very much. Well, firstly, as it relates to the over 60s, we anticipate that that process will get underway in earnest for April. You may have some overlap. Well, you will have, because you'll have healthcare workers who are over 60 who will be given greater priority, and you may have institutions that may have completed their healthcare obligations and in that region, and you may have some overlapping. But the main program with the sort of advertising, the invitations, the active sites, the appointment setting and so on, we're looking at April to start that program in earnest. And as I said earlier, more information will be provided around that. As it relates to the marketing program around, or the communications program around wearing masks and physical distancing and so on, as far as I know, that is ongoing. I mean, I do see the ads in the print media, on TV. We do have town criers around in different parishes. You said you've heard, but it is your MP, but there are town criers that are going around now. And we have the community health aides who are out in the field. Remember, we had hired a number of them, and they do on-the-ground community activations. If you're suggesting that we need to do more, then we'll take it on board, we'll examine it and see if more needs to be done and what else can be done. But I do know that it is happening now. What has happened in recent times, though, is that there has been a shift somewhat to the vaccine program. But we can check to see how effective what is taking place now is, and whether we need to increase that.
Thank you very much, Minister. I am not seeing any more raised hands, so I think we have an early evening. There's one more actually. Okay, they're raising their hands now. So we're going to go to Debbie and Wright from the Gleaner.
Good evening. Are you hearing me?
Yes, go ahead, Debbie.
Okay. Oh, just a quick question. Are there persons who would be excluded from taking the vaccine? I know it won't be given to children, but for example, persons who are severely immunocompromised, are there any list of persons who will not be getting the vaccine?
So to answer that question.
Thank you very much. The contraindications are mainly to allergies to the components of the vaccine, as well as an allergy to the first dose of the vaccine. However, there is a concern among persons who are very frail. So you're very old and frail, your immune system is not robust at all in any way, and those persons will be taken under consideration. It's the clinical assessment of those persons before we administer the vaccine to them. So if, for example, we are offering it to persons who do have cancer, but if they are stable, if your white cell count, for example, is so low that you could not manage chemotherapy, then we wouldn't be offering you the vaccine at this time. So really, we look at the individual, we assess their status, and then we vaccinate accordingly.
Thank you very much, Dr. Reines. We're going to go to Stevion Simmons from Nationwide.
Hi, good evening. Can you hear me?
Yes, go ahead, please.
All right. My question is for Minister Tufton. Are there any plans to use private doctors and private facilities to administer the vaccine? And if yes, what sort of measures are in place to ensure that any such plans are in keeping with the ethics and other principles of the vaccination program?
Right. So the vaccine program, first and foremost, as suggested in the early stages of the plan, where we speak about equity and transparency and so on, is going to be coordinated by the Ministry of Health and Wellness. So we will ensure through the overarching management of the program that equity and the other critical principles of access and universal access and reliability is maintained. And that is standard operating procedure for immunization programs, not just in Jamaica, but in other parts of the world. As it relates to this program and the national crisis that it represents or it tries to solve, we recognize fully that there is a need for all hands to be on deck and to engage all the stakeholders to play a role, particularly in what will be probably the most significant mobilization program that this country has seen in memory, if not certainly post-independence. 2 million persons to be vaccinated or inoculated over, let's say, 11 months or so. It's a big task, and it involves national mobilization. So the idea is to define a role for as many critical stakeholders as possible. So the Army is involved, the constabulary, the critical community-based organizations, public health, of course. The private sector generally is playing a role, and we have consummated that through a MOU that was put together, which outlined their role. Private doctors are an important part of that process. So, for example, we have 3 phases of implementation of the vaccine. One, the third phase being a blitz, where we will establish these large centers, whether it's a national arena or otherwise. And the intention there is to get private doctors to man the throughput at those locations, even while we have the public players dealing with the health centers and the hospitals. So that's one key role. There are other roles that we think private doctors can play, and that may even include, or is likely to include, certain locations that are privately owned. We're working through some of those details now, and we will make or provide greater specifics around that. But whatever we do in a specific response to your question, we will ensure that no one is denied access to the COVID-19 vaccine based on their ability to afford or the lack thereof. And all will be given an opportunity within the protocols of the vaccine to be able to access that vaccine. And that principle, the government and the ministry will ensure prevails right across the board.
Thank you very much, Minister. There's a question here. What is the vaccination recommendation for persons who have had an organ transplant, and where do they fall in the order of priority for vaccination?
Organ transplants are persons who would have had and continue to have an underlying condition. Once these persons are stable, they have no ill effect from their transplant, they continue on their medications, then these persons can and will be offered. Again, they are in a priority group or in one of the priority groups because they would have and continue to have, as I said, a comorbid condition. Again, if these persons are very frail, then we have to look at them in detail prior to offering them the vaccination.
Thank you very much. We're going to go to Zara Burton.
Good night, everyone. I wanted to ask a couple questions, one being, what's the guidance on those people who may be concerned about fertility and its potential effect on fertility? What is the guidance from the ministry on that? Also, I wanted to know, last time around there was a presentation by P.S. Bryan, and there was a vaccine card mentioned, that once you actually get a vaccine, you'd get a vaccine card. And I wondered, what is the purpose of the vaccine card? And then 3, I was also wondering about the private sector company, if that has yet been decided upon in terms of who is sourcing vaccines. I know the MOU was signed, but who is specifically the private sector company that was supposed to source vaccines according to the PS some weeks ago?
Thank you very much. Let us start with the second question, which is the immunization card. So all persons in this country from time immemorial, once they are vaccinated, they receive an immunization card. And in 2010, we not only gave a card, we gave a passport, the Child Health Development Passport. So all the immunizations that persons receive from birth all the way through to adolescence is recorded in that document. So this card follows the same line. It tells that you have received the vaccine, the date you receive it, the manufacturer, the batch number, routine information that we have always given to persons is placed on this card, and the card is kept safely the very same way you keep your children's cards and the Child Health Development Passport. So that's the card question. The infertility question, that has been coming up a lot, and there is no evidence at all that this vaccine or any vaccine that has been made over the many years have an impact on fertility. There is a particular protein that is of concern to persons, the syncytin-1 protein in the placenta, that persons believe may, once affected, may cause infertility. Now, the composition, the ingredients, the components of this vaccine and the other vaccines that have emergency use authorization from PAHO WHO has no amino acid sequence at all that could affect this placental protein. There has indeed been cases of persons who were in the phase 1, phase 2, and even phase 3 clinical trials that have become pregnant, and some have even delivered bouncing babies already. So that's definitely one of the myths that is surrounding this vaccine. The third question was that of the private sector sourcing the vaccines. Now, private sector is indeed sourcing. However, all vaccine manufacturers at this particular time is really only speaking to governments. So there is no private sector anywhere in the world that can actually procure vaccines. What happens is that they can source, they can fund. However, it has to be the government of each country that takes vaccine in. So for us here in Jamaica, it's the National Health Fund. We speak with the private sector, they do source, but it has to come through the government system, and it follows all the guidelines accepted by the government of Jamaica.
Thank you very much. We're going to go to Deon Jackson Miller.
Hi, good evening. Couple questions. One, there's something I thought I understood, but I'm not sure I do. So the 50,000 doses, is the plan to, is it that you vaccinate 50,000 people and then the second dose, when you get more vaccine, then you go for the second dose, given that I know the research has been showing that you know, dose 1 does give some amount of protection, or are you trying to give 25,000 people the full coverage of both doses first? So that's question number 1. Question number 2, are we going to be checking to see whether any of the other variants, the South African variant or the Brazilian variant, are here in Jamaica as well? And my third question relates to deaths, but it has to do with breakout of some numbers. So I think what I'll do, if it's okay with you guys, to contact you afterwards for some more detail on that. Would I be able to do that and get some more breakdown on that?
All right, I'm going to ask. Yes, you can. You can make a contact, and we will, Dr. Webster-Carr will try to facilitate as best as she can. But on the other two questions, I think, Dr. Ennis, you're the most...
Yes, sir. So, this is Jackson Miller. With regards to the 50,000 doses that we have received, we will be vaccinating 50,000 persons. And this is because we have ascertained that once we are utilizing the AstraZeneca vaccine, it matters not where we get it from. It is a generic AstraZeneca that is important, and therefore we can administer, should we get AstraZeneca from a different source, it matters not. It's acceptable, and therefore we have opted to vaccinate 50,000 persons. Now, it's important to remember that we have also altered the spacing of persons being vaccinated. So we are no longer, or we haven't started at all, to vaccinate 1 and 4 weeks, because the efficacy of the vaccine actually improves if we wait 8 to 12 weeks. So based on the schedule of arrival of vaccines in country, we're pretty confident that we can deliver the 50,000 doses, and we will have vaccines at the end of 10 to 12 weeks to begin administering the second dose. So we have opted to go with the 50,000 persons. With regards to variants, I think I'm going to hand over to Dr. Webster-Carr to take that one.
Okay, thank you. So we will be testing for the other variants. However, apart from the UK variant, it takes twice as long to get back those results. We are also in the process of starting the procurement for a machine so that we could do the genetic sequencing here in Jamaica and to allow for continuous surveillance for all of the variants, those that are current and those that may come. So the answer is yes.
Thank you very much, Doc. I'm going to go to a follow-up from Stevian.
Hi, good evening again. I just wanted to find out, persons who are disabled, persons who are deaf and visually impaired, are they considered among the priority group?
If these persons are old, they're over 60, they have comorbid conditions, absolutely. But we are also currently working on a specific protocol to address persons who are disabled, because we know that how we inform them will have to be a little bit different from how we are informing the general population based on the challenges that they may have. So we have a special plan to focus on the disabled. You may also realize that a lot of these persons are not mobile and may have difficulty getting to us. So we have to certainly consider going to them. And as Minister mentioned, one of the possible options of the private sector and the private doctor are doctors who actually do home visits, who know these persons. So there is a plan to be rolled out to specifically target the disabled, but if disabled persons fall in any of the priority groups now, then certainly they will be vaccinated in this phase.
Thank you very much, Minister. A final question from Job Nelson from Loop. He's asking, how do we know the true reflection of the figures and the severity of the situation on the island if tests are being done by unauthorized labs?
The data that is collected and used to model and to conclude on where we are is based on certain protocols that have been established, training that have been done, and authorization given to labs to conduct this exercise. It is that data that we use to determine the extent of the virus on the ground. Of course, it's done with, within margins of error, meaning it's not a precise science, but it gives a fairly good indication as to what is happening. Now, the unauthorized labs don't factor in that data because we deal with the labs that are authorized. And so they may have their own interpretation of what is happening at any point in time with the persons that they deal with. We do encourage and advise Jamaicans to go to the authorized entities. And we believe that with those entities, it gives us enough information to project and to make certain conclusions on the extent of the virus in the population. And we think that it has been relatively accurate or fairly accurate to date, as manifested in some of the projections and the forecasting that we have made, which have turned out as shown on the chart earlier when Dr. Webster spoke.
Thank you very much, Minister. At this time, we have 4 questions from the media. I'm going to hand back to you for your closing remarks.
Okay, so we've been here for a little while, so let me quickly just thank all who came on today. Dr. Ennis, Doctor who is in charge of the vaccine program, head of family medicine, Dr. Webster, our chief epidemiologist, and we have Dr. Nadine Williams, who is here, and the permanent secretary, who is also here giving support, and he is playing an important role in the vaccine rollout program. For the technical team, thank you very much. Stephen, of course, as usual. I want to say that the challenge that we face right now is really about the protocols as we seek to get the vaccine in the wider population. And that is going to take some time. That's the key message. It's a function of having the vaccines and then managing the vaccines through to the arms of individuals across Jamaica. We are confident that a vaccine is a significant solution or response to the COVID virus. We're seeing it playing out in other parts of the world. We have taken our time to do it right, to get vaccines that are WHO approved, and we have a plan to implement, to roll the vaccine out across the country, but it is going to take some time. And so the social distancing, the mask wearing, the sanitizing is going to be absolutely critical. As what is happening now is that we're going through perhaps the worst period we have seen, and it is measured by the impact it is having on our public health system and the lives that it is claiming. We believe that if you follow the protocols, we will be able to cauterize it, and we will see better days even while we roll the vaccines out. And that's our encouragement to Jamaicans tonight. I want to thank the team in the field who have been working diligently, who have been managing the vaccine rollout on day 2, and who are committed to continuing that process. We really believe that they are heroes and they are doing the best they can, and we know we will have greater capacity as we go along. The partnership is important, so thanks to those who are not public health, but who are partners in advancing this cause. Thank you very much. Have a good night, and we will keep in touch as we seek to respond to COVID-19 and make Jamaica a better place as we restore normality to life and to livelihood. Thank you.